Good morning, everyone. My topic is delayed refractive correction after traumatic cataract surgery 30 years back with piggyback IOLs to rescue. Next, please. I have to do myself. Am I right? Okay. Traumatic account for a significant proportion of cases in young patients. While initial cataract extraction with IOL implantation is common, long-term complications like myopic shift, posterior capsular classification, PCO, capsular bag fibrosis can severely impair vision years later. Let's go into the past, 1996. Patient came to us with a history of trauma, blunt, 2 months back, and complained of blurring of vision. Age was 13. She was a female and agricultural laborer. Ocular history sustained blunt trauma to the right eye 2 months back, underwent uneven cataract section with IOL implantation at a Kala hospital. Postoperatively, she regained 6-by vision with the uneven recovery period at that time, 30 years back. Patient was lost to a follow-up and came in 2025. Now the age was 43. Female agricultural worker, ocular history, sustained trauma to the right eye at the age of 13, underwent uneven cataract section at that time. But now the presenting complaints were progressive vision deterioration in the right eyes since many years, severe blurring, difficulty with work and daily activities. So this is the picture of the, you can see a big yak capsule done by someone else. We had put the lens in the bag. At that time it was an uneven full surgery. So she has visual eyes 6/6, finger counting, and right eye in the left eye 6/6. Visual acuity BCVA was 6/18 in the left eye and 6/6 in the left. In the right eye and the left eye. Affected eye was 60/18. Intraocular normal, slit lamp examination, pseudophakia, big PCO, a capsular bag, fibrosis, yak capsulotomy, and otherwise normal. Anterior segment OCT, intact ciliary sulcus anatomy. Key diagnostic assessments. High myopia of -10 diopters in the right eye, affected eye, the traumatic eye the patient had undergone so many years back for cataract surgery. Capsular fibrosed, capsulotomy defect confirmed by slit lamp examination, prohibiting safe intraocular removal of exchange of IOL. So it was difficult to exchange IOL because there was a big defect in the posterior capsule. Laser procedure could not be done due to high myopia. So epi-LASIK, whatsoever we have, and we couldn't do. So we planned a procedure, secondary sulcus placement of a foldable sulcoflex, aspheric monofocal piggyback lens. So we saw the silky sulcus and all that. So I think this is the video. Yeah. So short video. So you can see a lens in the back with a big posterior capsule defect because the capsulotomy done somewhere else. All these sizes are done on 3D. So lens were implanted into the anterior chamber first, then shifted to the ciliary sulcus. I can't show you how beautifully and how clearly this. You can see these things on 3D. And it's so easy to do these things if you have a 3D. So you can see the haptics, optic, haptics. This lens has got 4 haptics. big haptum, it's a little difficult to put in. It goes behind into the sulcus. Two haptics are still outside in the AC. Hydration of incisions. We normally in such situation we do aspiration not with the aspiration cannula but with the retractor. Aspiration with the retractors. If there is any vitreous, you will cut it also. So there will be no traction, there will be no complication of the posterior segment. That's a routine at Trachal Hospital. When in doubt, use the aspiration with retractor. So this was the picture. Of course, she had so many years back and easy some sunny care, but the circus was okay. So the pupil is not properly contracting, but on the, you should see, after the round pupil, now we'll remove the cerebral also. So now this patient has two lenses, one implanted how many years back, and the second one now. And I don't think there was any other procedure other than this to correct this refractive error. By any corneal procedure, and another alternative was to remove this lens, which was not easy and would have been very traumatic and involvement of the posterior segment. Postoperatively, well-rounded pupil, visual acuity was 6/9, patient happy and smiling. Thank you. This is how you do skydiving.
I think you have written your age wrong, sir. It's not 73, it's 23. So now coming to such kind of cases. So I prefer to do a little bit YAG anterior. I cut these release, this anterior capsule.
Yes, of course. You bind them, you cut them.
Yes.
Rather, when you start, you pass a cannula behind
Yes.
and see what is happening around.
Yes.
And most of the time you don't require it. You just pass a cannula behind.
Yeah.
And you will very well make out what is happening in the silly surface.
Yes, definitely. And means Kinacot, I would have preferred.
It is routine.
Yeah.
It's a routine. Always routine. I haven't shown it, but it's a routine. This patient also must have done.
Yes. And
Kinacot and aspiration with the tractor, not with IA. That's a routine.
And in few cases, we have also used ICL also.
Yes, you can.
As a piggyback.
In fact, we have also used.
Thank you, sir.
And this
But
patient didn't
you
have any
need to have
amblyopia component.
those
That was the
parameters.
greatest part, because
Yeah,
in spite of a minus 10 diopters of refractive error, there was no amblyopia.
Yeah, but
Yes.
minus.
Minus
Patient
10.
minus, they don't
Yeah.
go to amblyopia. If it was plus, it would have gone to amblyopia.
Cannot reach. Sorry.
May
Thank
I
you,
take
sir.
permission? May I take permission?
Thank you, sir.